For decades, a few lines of text, a black box warning, kept millions of women from using even low-dose vaginal estrogen. Now the FDA is reevaluating that label and the science that tells a different story. Today we're exploring what this shift really means and what the future of menopause medicine looks like. Welcome back to All About You. I'm Dr. Shauna Watts, GP and women's health advocate. Each week, I bring you evidence-based conversations that help you navigate midlife with clarity and confidence. If you've ever felt dismissed or confused about what's safe after cancer, this episode is for you. By the end of today's episode, you'll understand how you can have the confidence to use vaginal hormones in almost every situation, including women who have breast cancer. The FDA changes every woman should know about and why they should finally shift the conversation on hormone safety and why women navigating menopause after cancer deserve real support, not silence or just cope advice. As always, this is general information only, not personal medical advice. Please consult your own healthcare provider for guidance. My guest today is Dr. Corinne Menn, a board-certified OB-GYN, menopause specialist and breast cancer survivor. After her own diagnosis in her 30s, Corinne experienced firsthand how little support and evidence-based guidance existed for women facing menopause after cancer. That experience reshaped her career. Today, she's one of the most trusted voices globally in this space, combining clinical expertise, cutting-edge research, and lived empathy to advocate for safer, smarter, and more compassionate care for survivors. I'm so excited to have Corinne Menn back on the podcast today. Let's get into it. Corinne, do you think that women who undergo very early or early menopause have a unique presentation or a different presentation than women who have a later menopause, and especially those women who have like a surgical sudden menopause? Do you think they present differently?
Sure. It's a crash menopause. It's abrupt. It's happening overnight. Perimenopause is no walk in the park, right? But at least it's a time of transition, right? You've got years to try to figure it out. And during that time, you're still making estrogen and progesterone, but just in erratic amounts, sometimes high, sometimes low. So you've got time on your side to figure things out. With surgical menopause, or some other medication-induced menopause that's very abrupt, there is no time. There's no transition period. And you go from all to nothing overnight. So these women need to be prepared because that very abrupt withdrawal can trigger not only worse, more severe hot flashes and night sweats, but can really provoke significant mental health issues, mainly because of setting off insomnia, setting off new onset of anxiety. And it also greatly increases the chronic disease risk acceleration. All of those things are very unique for a surgical menopause. And what's a shame is that these women know they should have counseling because it's something that can be predicted, right? We can't predict exactly when your perimenopause or your final menstrual period is going to happen. But when we're cutting out your ovaries, we know exactly what's going to happen. And so if you're the surgeon doing that and you have not given her pre-op counseling, and made a plan for how you're going to manage the estrogen deprivation, then you're not doing your job, because you would not take testicles off a man and not have a conversation about what you were going to do about that loss of testosterone. You would have a plan. They always have a plan, but most of the time women don't have a plan, right? So I think that's the main difference. And it's really a shame because it's needless suffering, because we've got guidelines and we know what to do.
Another group of women who I think are very active on social media and are coming more in their droves to see me are women who really have missed out on hormones. So they're probably in their 60s and 70s now. They were that cohort who were right in the heart of whenever WHI exploded. Certainly I remember I was a very young doctor and I remember it being all over the news. Everyone was talking about it. And these women, it was just never even an option. It was not discussed. They weren't allowed to have it. And that was that. Some of them are appearing because they've still had symptoms. They've had 20 years of symptoms and they're kind of done. And then there's another group who don't have symptoms per se, but they're really upset because they've found out they've got osteoporosis, or, they're maybe nursing a much older parent who's got dementia. What's your approach to those women?
So listen, I think that these women deserve shared decision making and they need to be, counseled on a very individual basis. So I break it down in somewhat of a similar way that I do actually with the breast cancer survivors. First, I want to know, why are you interested in hormones, right? Sometimes it's just like kind of dispelling some fears and kind of going through like what they're looking for. So let's take, there are patients who still have persistent symptoms. So, that's actually in some ways an easier, not necessarily, but it's an easier conversation. We know there's a subset, at least 10% of women who will have hot flashes and night sweats and then resulting insomnia forever, right? Like they just don't go away. They're there, right? And we know there's lots of secondary, I don't want to say secondary, but other symptoms that are not primary indications for hormone therapy, but we can all recognize they're part of menopause, whether it's achy joints and, um, you know, skin issues and anxiety and all these other things that, can be related to that loss of hormones. So I want to know, what are your symptoms? What have you done for them, right? Like, did you ever use hormones? Were you on it for 5 years and then suddenly you reach 60 and someone said you had to get off it? I look at that patient a lot differently than I look at someone who is, say, 68 who was never given hormones, right? So it's not just how old they are. It's like, did you ever use hormones? Because if you used hormones for a period of time and then were forced off of them, you had some kind of benefit time, right? So you're not, I don't look at you as someone who is, without it, in terms of like, did you have some protection and you probably blunted some of that cardiovascular disease accumulation that we know happens with that withdrawal of estrogen. So you kind of have to look at that too. And then I ask, like, is it mostly genitourinary? Because we can start vaginal estrogen without controversy on anybody of any age. Like, I don't care whether you're 80 years old and you've had a massive heart attack and you already have dementia. We can use vaginal estrogen so that you are less likely to have urosepsis and you're less likely to wind up in the ICU, to wind up in the ER, et cetera, right? Or, have cognitive changes because you have an infection and then you fall and break a hip, right? Like, vaginal estrogen saves because it prevents all of the negative downstream effects. So if that's your main thing, that's easy, right? If it's symptoms, then we have shared decision making, right? We can talk about non-hormonal options for things like hot flashes and night sweats, but they have their own side effects. And the newer ones are new and can be expensive, but we can talk about them. But if we're going to start something for symptoms, and you want to see if it helps you, then generally we would offer a transdermal, generally estradiol with a progesterone if you have a uterus. If you don't have a uterus, we could just do estradiol alone. And in these women, I generally will start with a lower dose. And I also will assess, like, what are their risks if I give them that hormone. And I just have to tell them, if you're choosing to take the hormone because you think it's going to reverse heart disease or stop dementia, that ship sailed actually, in terms of cardiovascular, cognitive decline, dementia, because once disease has set in and it's been more than 10 years, we can't put the genie back in the bottle, right? If there's atherosclerosis and there's plaques, they've already accumulated, and giving us estrogen now is not going to make them go away. It doesn't mean you can't use it. And anybody who's interested in this, learning more, in JAMA was just published this summer from the original WHI investigators, reanalysis of their data, and basically saying, like, well, you know what? Actually, in the 60 to 70-year-old range, actually, their cardiovascular risk was not that great. Wasn't that significant if they were given hormones. And remember, those were women who were given synthetic oral estrogen and synthetic oral progestin. So we actually have some data that 60 to 70-year-old group, it's probably not so dangerous to give it to them, but I just have to tell them, I don't think they're going to get huge cardiac benefits, but they might feel better and sleep better and not have hot flashes. But what they're not going to lose is the osteoporosis benefit. So it's very reasonable to say to them, okay, low dose, a transdermal estrogen to minimize blood clots and cardiovascular events, and even a very, very low dose of estrogen can prevent osteoporosis. And if you already have osteoporosis in one part of your body, it doesn't mean that other parts of your spine or your hip wouldn't benefit from prevention of further loss. Now, you might need a medicine to treat your osteoporosis and help it in other ways, but we can also prevent further loss. And the data has shown that you can use very small amounts of estrogen in these women. They don't need a lot to prevent further bone loss. The people who I'm much more cautious about is someone who is particularly close to 70 or over 70, and they might have a lot of other health problems by now. Like they may have significant heart disease. And we want to be really careful because giving them estrogen then, if they have a plaque in one of their blood vessels and their coronary arteries, even things that we can't see, that estrogen could just soften that plaque, make it a little unstable, and it could move and cause a stroke or a cardiac event. Now, that risk is still quite rare. And, for an individual woman with informed consent, she's a big girl. She can choose to do that, right? It's all about explaining risks and benefits. So I don't believe in there's some absolute no time, right? Um, and this is why we have to educate clinicians because they don't know how to handle these women, but there's millions of them who want an answer. And I say you deserve a discussion, just like the breast cancer survivor deserves a discussion, right?
Yeah, absolutely. I can't remember whether it was on your Instagram, but I saw an interesting graph that showed prescribing of hormones as they went down from 2001 onwards, and then the prescriptions for SSRIs, anxiolytics, and like diazepam and things go through the roof. And it's so interesting because a lot of that group of women who are in their 60s and 70s are all taking SSRIs or sleeping tablets and things like that. And some of them do present and say, I'd love to come off these. Can I perhaps transition? And do you think if I go on hormones, I'll be able to come off these? I mean, obviously, I can't promise that that is the case, but these women are
Yeah.
quite motivated that they would like to come off some of these medications.
You make a great point, and that slide was from, I'm gonna shout her out, Dr. Heidi Flagg. She's M_pause on Instagram, and she does a beautiful job on some slides, and so she put that data together and just kind of showed by looking up, like, what were the prescription numbers, and it's really astounding. We should be afraid of polypharmacy more so than HRT. Polypharmacy means people on multiple medications, and, right, the elderly, older women and men are at a very high risk to be on multiple medications, like more than 5 medications, right? And so when you look at those lists, a lot of them are anti-anxiety medications. There are sleeping pills, pain pills, lots of things like that. It's actually really heartening when you actually can take women off of some of those things because we don't inform women that these medications have risks too. SSRIs increase your risk of bone loss. This is not controversial. There's actually serious papers, serious research studies that have shown that there is accelerated bone loss and an increased risk of osteoporosis with SSRIs and the longer duration of SSRIs. Because why? There are serotonin receptors inside your bone. I don't know the ins and outs of the mechanism exactly, but it's quite well documented. SSRIs can also lower libido, cause sexual dysfunction, right? Our older patients deserve to have a healthy sex life. And sometimes the SSRIs are really impacting that. And we always have to ask, why are you on these medications? Now, sometimes women need them for anxiety, depression, and they can be life saving. I am not here to tell women not to take an SSRI, but always reevaluate why you're on it. And then the anti-anxiety medications, and the sleeping medications and some of the pain medications, things like Neurontin, gabapentin, some of these bladder medications for overactive bladder, these increase risks of dementia, of, mental, cognitive changes can make people feel, kind of cloudy and put them actually more at risk for falls. So we really always have to be reevaluating, like, what are we really afraid of sometimes, right? So, I mean, you make excellent points about all these people on these medications.
I have one other question for you from a patient, which is um, I developed high cholesterol since I've gone through menopause, and I'm now on cholesterol medication. If I had taken hormone replacement therapy, would I not have needed to take the cholesterol lowering medication?
We don't know that for sure. Okay. Listen, I'm not against statin therapies. There are cholesterol medications can be really important treatments for certain women who need to, lower their lipids, right? Um, So we shouldn't be afraid to use them, but we also shouldn't be afraid to inform women proactively that the menopause transition is a time of cardiac disease risk acceleration, including a slow uptick or sometimes a fairly quick uptick in LDL, in the bad cholesterol, lowering of your HDL, increasing in triglycerides, increasing in insulin resistance, pre-diabetes, inflammation, all of these things that affect heart health. So what I would love would be for that woman to be informed that her hot flashes are directly linked to cardiovascular disease risk. And that maybe if we started hormone therapy early, we might attenuate some of that, increase. Now, some women with age just naturally they do have hereditary factors that would make their cholesterol go up. So I don't want to make women think that we should be treating their cholesterol primarily with hormone therapy, but we should be informing them that if you use hormone therapy, it's likely going to be of benefit because we actually have really good data on what it does to your cholesterol levels. It actually improves it. And actually, sometimes oral estrogen does a slightly better job than transdermal. So what I tell women is, well, let's work with your internist and see, like, maybe you start this along with your statin, or maybe you do this for 6 months and work on your lifestyle, pillars of lifestyle medicine, and maybe you avoid the statin. Or maybe you're going to use both. It's really interesting. We don't think twice about prescribing the antidepressant or the statin. Um, and I think it's a lost opportunity of so many benefits that women could be getting from these medications from HRT.
This episode is brought to you by my 16-week Rediscover You program, designed specifically for women navigating the challenges of perimenopause and menopause. If you're dealing with disrupted sleep, mood changes, or unexplained weight gain, this evidence-based program combines medical guidance, practical tools, and a supportive community to help you take control of your health. Women have reported significant improvements in symptom management of sleep quality and overall well-being. As an All About You listener, when you mention the podcast, you'll gain priority access for our next intake. Click the link in the show notes to learn more and join. I'd love to help you rediscover the vibrant, confident version of yourself. Corinne, I just want to pivot a little bit because everyone's social media feeds, even here in Australia, have been absolutely flooded with videos of what happened this week with the FDA. So for anyone listening, what is the FDA? It's called the TGA, similar thing here. But can you tell us what the FDA is and what the big news was that happened this week?
Yeah, really big news. And I was lucky enough to be invited to be at the press conference on Monday in Washington, D.C. at the Department of Health and Human Services. And we heard from the FDA chair and fellow physicians. And they basically made the decision to remove the black box label on estrogen containing products, right? It doesn't mean that they've removed warnings or information, but they're moving the information away from the highest level of warning, which is a black box, okay? And they're doing this based on decades, right? Really since the WHI came out and in 2003 when the black box got put on all estrogen products, experts, medical societies have been, talking and pushing the FDA to reconsider this black box. The official petition in the US, I believe I would say around 2015, 2016, and then the FDA denied that petition. That petition was to at least remove the black box from local vaginal hormones, right? Because what women have to understand, this black box was put on all hormones, all estrogen products. So whether it was a local vaginal product or a systemic product. So it was really important that vaginal hormones did not have the same label as systemic hormones because the label on vaginal hormones was just completely inaccurate. It said, or it, it says, causes breast cancer, heart disease, and probable dementia. There's no data point on earth that has ever said that about vaginal hormones. So there was unanimous agreement that that needed to come off. And yet, administration after administration, Democrats, Republicans, no one did anything about it, right? And so finally, this administration, which likes to disrupt things apparently, decided to go ahead and remove that on vaginal hormones. So we were so happy about that, right? That's a huge win. Huge win. Because as we were talking before, like vulnerable women like breast cancer survivors, or women who have a family history of breast cancer, or maybe older women who are like 70, who have maybe cardiac health issues, they read that insert. And even though the doctor says it's safe to take vaginal hormones, they're afraid to take it because of the insert. So then the other part of this is that the FDA went a little further, which I really applaud, and said, you know what? We're gonna take the warning off as a black box warning. But I want everybody listening to know, I was actually in a call with the FDA today, just a few hours ago. Leaders from the Menopause Society, other, advocates and other doctors who were very interested and, active in this space were on the call. And they really clarified a lot of things. They said, listen, we're in the business of accurate drug labeling. We want to just provide accurate information. And so what they're doing is going to take the information that was in the highest level black box warning, and they're going to move it down into the regular part of the insert. So it's not throwing the baby out with the bathwater. It will still provide information from the Women's Health Initiative on older women. But now it's going to require that they also include the information from the Women's Health Initiative on the ages 50 to 59, and showing that they did not have the same cardiovascular disease risks, right? And also clarifying different formulations. So they are inviting, right, the companies that make these products to then submit, new language. They will not, it will not, the black box will not be part of that anymore. But they can submit and say, hey, my transdermal estrogen product, the data suggests these risks and benefits. And what's really important is when they presented today, they kind of clarified some things from Monday, is that they are not getting rid of the information about cardiovascular disease risk or even breast cancer risk that was in the original black box. They're just moving it down to a regular information and adding additional information on contemporary formulations. And they are going to, in the label, be emphasizing the timing and emphasizing that the ideal time of initiation is in the first 10 years of entering menopause. So to me, it's just it's balance, it's nuance, it's providing more accurate information. It's not removing information, it's just making it more accurate, right? And what we hope is that it doesn't get in the way now of that patient doctor relationship, because when a doctor tells a patient something and then the label on the drug says something totally different, how can the patient trust us, right? And I also think for the doctors who aren't as well versed in menopause management, when they pull out the label, they're going to see a bigger picture, right? They're going to see all of the information, right? And I also we have to recognize that it's going to be a process. Like the FDA said, listen, there's products on the shelves now that still have this. Those labels are still going to be there. It's going to get time to go through that inventory. It's going to take time for the various products to then update their labels. So this is the start, I think, of a really good process. Um, and I think in the coming days and weeks, you're going to see more of the details coming out, because sometimes people like to blow up and get all crazy about stuff. People are really happy about it. Then some people are very negative about it. I think the people who are being really negative about this actually haven't even listened to the specifics about what they're talking about. I'm thrilled. I personally think it's a win for women everywhere. And perhaps, the world takes note and maybe there's a domino effect. That's what we hope.
Yeah, I agree. And I have to say, like you, I think I spend a lot of time with my patients. I have very long appointments, but sometimes, we go in all different directions and maybe we don't spend enough time talking about, oh, by the way, that leaflet in your vaginal hormones, like don't read it and don't freak yourself out. And I have to say, a worrying number of women do come back and they say, oh, I didn't start that one. I was really, really worried about starting that one. I mean, interestingly, they've often started this systemic therapy. And when I try and explain, do you understand how small a dose this vaginal dose is and really how transformational it'll be? But that leaflet just seems to freak people out.
Yeah, it's a barrier, right? And so we just want accurate drug labels. I don't think there's anything wrong with that, right? And removing a black box label does not mean removing a label. There's still plenty of information there. Um, And yeah, I'm really excited that this is going to just continue to highlight the importance of these hormone therapy options, and ease some fears.
I think the other perhaps positive will be that maybe it's going to draw the attention. And we've obviously in Australia got a really big general practice network. That's really the first point of call. That's where patients on the whole go for their cervical screening, a lot of their care. And it's just to perhaps get that group of individuals to also realize, oh, well, actually, maybe we need to relook at this, and maybe stuff that we were taught 20, 30 years ago, it's time for an update, because it's definitely an interesting time to be a doctor, because the patients are more educated than ever. And sometimes they come in with things and I have to say, listen, I actually don't know about that. I'm going to have to do my own research and come back to you. But I kind of love it because they're keeping us on our toes.
Yeah. And, I think during the announcement, some of the speakers, the head of HHS and et cetera, talked about that, there's data that suggests there's cardiovascular disease risk reduction or dementia reduction. And I do want to clarify to anybody listening that the FDA label change is not, they're not approved, they're not changing the of what these drugs are approved by. No one at the FDA is saying that that there's going to be a new indication for hormone therapy. The label is not going to say that now it's approved to prevent dementia or now it's approved to prevent cardiovascular disease. That's not part of it. It's just saying that that information, can be discussed with patients, right? And that perhaps in the leaflet will be included the data from the largest studies like the WI that says actually in women who started it earlier, there's data showing XYZ. So take this all into full account when you're looking at all of the benefits and weighing them against any risks that we know about. So it's still not changing that the primary four indications that we have for hormone therapy are for vasomotor treatment or vasomotor symptoms, prevention of osteoporosis, premature menopause treatment, and the genitourinary syndrome menopause treatment. So that's staying the same. They're just taking the scary black box, putting it into regular information, and then adding more additional information. So to me, that's a win.
And so in the vaginal hormones leaflet, are they removing the thing about dementia and stuff from the vaginal hormones
Yes.
completely?
Yes, they are completely, you know, here, I have the slide right here. They're going to remove, these are the specific changes, remove the language related to cardiovascular disease, breast cancer, and probable dementia. It's no longer going to be a boxed warning. They're going to remove the language related to endometrial cancer, except in the systemic estrogen alone drugs, right? So things about uterine cancer are going to be totally removed from vaginal estrogen, and removed from any combination products, right? And they're also going to remove the recommendation to use the lowest effective dose for the shortest amount of time. Labeling on a whole for both vaginal and systemic, they're going to remove the probable dementia warning because there is no data that says that using hormones are probably going to give you dementia. That's just terrible language, right? So I think that's really important. And then for the vaginal estrogen products, their language is that they're going to condense the safety information and prioritize information most relevant to the local vaginal formulation, right? So going to right size the label for the low dose of the hormone, right? And I do love that in writing they wrote they are going to retain information about cardiovascular disease and breast cancer warnings. It's not going away. It's just going to be put into context, right? And they're going to add WHA data from 50 to 59-year-old women, and add considering starting hormone therapy for moderate to zero VMS in women less than 60 or less than 10 years since menopause. I just don't know who could argue on any of those points because that's what the guidelines tell us to do, right? All of those points.
Yeah, 100%. Well, well done in all your advocacy in helping get these changes through. Um, Corinne, I want to finish by asking you just a few questions around ongoing monitoring of women who are on hormone therapy, and what the current best practice is considered to be. Because again, seems to be a bit of confusion. With testosterone, certainly I do very regular blood testing for my patients. But again, we know that the blood test on testosterone is probably not the best. But where are you with regards to measuring hormone levels? I even have patients sometimes come in and ask me, will I measure their progesterone level? And if I'm being entirely honest, I don't even really know. I'm like, well, I'm not sure what I would do with that. So could you help me understand and my listeners understand where we are in that space?
Yeah, I'm sure we're probably very aligned. I mean, when it comes to testing blood levels, you know, unless we have a patient who, I mean, listen, I think there are some, certain circumstances, someone's really, they have lots of symptoms and you've tried formulations and it's not making sense that they're having all these hot flashes. Is it wrong to test a level and just see, like, are they absorbing it? I think we do have to be careful even in those situations because we know blood tests are just a point in time. So depending on when you apply the patch, how far away from when you put the patch on or took your pill or took your gel that you had your blood drawn, how much that's in the blood is reflected, how much is being um received at the receptor, right? Because really the blood estrogen doesn't do anything. It's what estrogen gets delivered to the receptor and how sensitive is that receptor to that hormone. And an example was so if a woman wants to know her estrogen level, she could have her estrogen level, right? Like we don't have to vilify someone who asks for a level. I'll do your level if you really want to. I tell them I'm likely not to change how I'm going to prescribe it, but I don't think women should be told no, that they can't have a blood test done. I explain to them that the progesterone level is really kind of not very meaningful to me because we are going to use the dose that we know has been well studied to protect your uterus, right? I'm not shooting for a number, right? I really agree. I don't think there's much of a role with the progesterone. Now, there is some talk, and I think this is valid, right? But I think we're not totally there in making this guidelines yet. But that there is for the younger woman, the newly menopausal woman, likely a more ideal level of estrogen in terms of ideal bone protection. We don't know what that level is for cardiovascular, benefit, right? When we're starting it early. But there's decent data that shows that around a 60 picograms per ml level for bone might be good. But again, there's no guidelines that tell us that. So I practice by not checking levels and using the appropriate standard doses that I know are safe and have been studied, and using the ones that meet her symptoms and minimize her side effects. I would never pump up a estrogen level just to reach some arbitrary number and then cause a woman to have bleeding or bloating or breast tenderness. That defeats the purpose, right? And again, I'm not on the woman who I know, she's 35 or she's 40. I'm not going to give her the lowest, right? I'm going to give her the higher dose. Now, there could be a case to be made that for these younger women, perhaps we should be checking to make sure they're actually getting enough estrogen so that, they're very young to protect. But I guess the case could be made that we actually have studies showing that these higher doses that are FDA approved and licensed, have been shown to be helpful and protective. So, um, I think I'm the camp that maybe in the future there'll be more of a role, but I don't think we're in prime time now where we should be routinely recommending monitoring hormone levels to make adjustments to your treatment. With the exception of testosterone is important. If you're using testosterone, we don't want it to be too high. And we want to just see, like, are you, we get a baseline and we can kind of compare, has it been raised? What's going on with it? There's lots of issues with testosterone testing in terms of getting a good quality test, et cetera. And there's a lot of noise on social media out there on, Dutch tests, saliva testing, all these estrogen breakdown pathway tests, which, patients come with reports that are like pages long. Maybe they're interesting, but like they're not clinically actionable. We don't know what to do with all those metabolites. I'm sure do they do that in Australia?
Yeah, sometimes they get blood tests that are sent away to Europe and things. And to be honest, I'm kind of like, ooh, I don't really know what to do with this.
Yeah, and I think it really comes down to listening to the patient. Though the patients who have this done, they've also often been dismissed by other doctors, and so this other doctors finally helps them and like ordered all these tests, and they feel like, oh, the doctor's listening to me, which I get, it's very validating. But then I try to talk to them like, well, you know what, just let's put this as sun. What are your symptoms? How are you feeling on your given dose, on your given formulation? What are your side effects? What's happening? And I could probably manage you a lot better if I just listened and took a good history than chasing down some breakdown metabolite of something. And then we do have to remind patients, if you're in perimenopause and someone's telling you what to do based on levels. Your ovaries are doing all sorts of things every day, up and down, up and down. And on any given day, it's going to change. So we would never use levels in perimenopause. We would use levels in premature menopause to diagnose premature ovarian failure or ovarian insufficiency. So it's more of a diagnostic thing, right?
And what are your thoughts on using testosterone in a post breast cancer patient who is struggling and very distressed by low libido?
I don't think it's off the table. I think it's something we should consider being able to have a conversation with. So the way I approach this is, one, I want to make sure that their libido is not caused by untreated GSM. So if they have painful sex and atrophy, etc., we want to optimize their vaginal hormones, right? Definitely want to do that first. We always want to recognize that low libido is biopsychosocial, and cancer survivors in particular have so many reasons why they have psychosocial stresses, relationship stresses, etc., that must be addressed. But we also have to recognize many of these people have had their ovaries removed, so their natural testosterone is quite low. And I think this is pretty easy because you can give somebody low dose testosterone, global position statement, using the appropriate physiologic testosterone dose for low libido. You can start it. You could check their level at 6 weeks, 8 weeks, 12 weeks, whenever you want to do that. Look at this interval and you could give it a trial. Anything that a woman does for 3 months using that approach is not going to make or break anything in her life. And if it gives her relief, you could, if you wanted to, also keep an eye on an estrogen level. Like in that case, let's say they're not also taking estrogen and they were only using testosterone for the libido. I think that's very, very reasonable. And you find in these cases that they at least 50% of them I find will improve. It will increase, sexual desire, more sexual thoughts, often better orgasm and a little bit better sexual functioning because there's a lot of testosterone receptors in the clitoris and the vulva. And when you check their estrogen levels, it doesn't go up because we're not giving them large amounts of testosterone. Now, if you have a testosterone level that's much higher, some of it's going to convert to estrogen, right? But if you keep it in a lower amount, it's a pretty safe and easy thing to do. Um, I will point anybody interested in diving into this more. It's in a link in my bio. We can put it in the show notes. It's going to be published in the Menopause Society Journal officially in January, but it's already online, free for anybody to look at ahead of print. It's open access. Sarah Glynn and her team out of the UK, including people from the US and all different disciplines of GYN, oncology, breast surgery, etc., did a beautiful consensus statement on the use of hormone therapy after breast cancer. What does the evidence show? How can we stratify risk? And they go through every scenario: testosterone, estrogen, vaginal hormones, as well as the different types of breast cancer, DCAS, triple negative, the ER positive. I think it's a fabulous paper. And so I would point anybody who wants to talk more about that to read that, and also read the Menopause Society in the US, also published a practice pro um, just recently on how we can think about talking to our breast cancer survivors. So I think those are the two top publications that have come out in this past year that I think both professionals and women can use as a starting point. And that way they don't feel that they are, you know, out there doing crazy stuff. Like, no, no, no. Serious people, serious medical societies, serious publications are talking about this, printing, and just admitting that we need to have the conversation. So, two great resources. Do I think we have perfect data on any of this stuff in breast cancer and hormones after breast cancer? No, we don't. And that's why the study, the first study I was talking about on this consensus statement that was published, is proposing a trial called the Meno ABC trial, which is just encouraging people all over the world. Hope in 2026 they're going to have parameters and ways to get patients enrolled. Can enroll any breast cancer survivor who is doing anything with menopause treatment, either non-hormonal, hormonal, vaginal, estrogen, testosterone, anything, have them all sign similar consent, get counseling, and let's just prospectively follow these patients instead of losing them and losing their data, right? Because we know it's happening. I prescribe to those patients. I know you do too. You're giving them shared decision making and options, but we're not collectively capturing that information that we desperately need. So I think that's a huge win, right? So I'd say that FDA label and like this new discussion and like talking about collecting this data, this is really hopeful stuff.
Yeah, absolutely. Thank you so much. We will definitely get all those details onto the show notes because I think that's beneficial both for really interested doctors, hesitant doctors who are quite scared in this space, and of course,
Right.
patients who are listening who want to know more. Corinne, you have been amazing. I have picked your brain to death, and you have been so generous with your time and knowledge. I'm going to give you the final word of anything that you would like to get out there that you feel is something that you want to sort of stand on and get people to pay attention to.
I want all doctors who care for women. And if you're a patient who is seeing one of these doctors, you have to push them. But doctors listening, please, please start taking seriously menopause, premature menopause in particular, right? There are more than just breast cancer patients suffering out there. There's a huge group of women out there who are particularly vulnerable. And while we are elevating the needs of those in natural menopause or regular menopause, we are leaving a lot of women who feel left out of the conversation. The most vulnerable women, the premature menopause, the cancer survivors, as well as the older women. I call them kind of this army of the most dismissed, right? So I want you to just think of like how we treat the most vulnerable women in this transition tells us a lot about how we treat women in general. And for those who have the most to lose, or that's these women, they have the most to gain when we try to figure out how to help them, right? We don't always have the perfect answer. So I beg you, if you're listening to this, try to think about caring for your most vulnerable patients. You'll learn so much from them, right? And you'll really make a difference.
Thank you so much.
Well, thank you.
Here are my 3 takeaways from today's conversation with Dr. Corinne Menn. Menopause care is survivorship care. Ignoring symptoms undermines recovery. Local hormones are safe for most survivors. The data is robust and regulation is catching up. Informed choices bridge data and dignity. Thank you so much, Dr. Corinne Menn, for sharing your expertise. You'll find links to Dr. Corinne's resources, including her clinical work and social media education, in the show notes. If you find this conversation helpful, please follow All About You and share it with a friend. And as always, this episode is for general information only and not a substitute for personal medical advice. Please speak with your healthcare provider for personalised care. I'm Dr. Shauna Watts, and I'll see you next time on All About You.